So, welcome to our fourth World Ovarian Cancer Coalition partner meeting. I'm Clara MacKay, CEO of the coalition. For those of you who aren't familiar with us, we are a global not-for-profit that works with 200 patient advocacy organizations worldwide. All share our commitment to a world where everyone at risk of or living with ovarian cancer has the best chance of survival and best quality of life possible. We also work closely with a global network of cancer agencies, professional bodies, and clinicians that share our commitment to this vision. So I'm really delighted today to introduce this session on the findings of an analysis of data from the UK ROCkeTS study that specifically looks at the impact of symptom-triggered testing and expedited referral for ovarian cancer. And I'm also delighted to be joined by Professor Sudha Sundar, who is very involved in this study. Professor Sundar is a professor of gynecological cancer with the University of Birmingham in the UK, lead on the UK National Ovarian Cancer Audit, and former president of the British Gynecological Cancer Society. And she stands out as a passionate and thoughtful global advocate with a deep commitment to tackling some of the real inequities faced by those impacted by this disease. So I'd love for you to start this off by sharing some of the data from the study and the publication. And then after that, we'll have a bit of a chance to have a discussion about its importance and implications. So I'm going to hand it over to you.
Thank you so much. Thank you for the invitation to present on the findings of the exploratory analysis of the ROCkeTS study on symptom-triggered testing and expedited diagnostic pathways for ovarian cancer. So I thought what would be really helpful is discuss a little bit about symptom-triggered testing, what the background to this is, what our data shows, and then where we can place this in the context of literature, go through some interpretations of that, and then we can have a chat afterwards about what this means more broadly. So these are my conflicts of interest. So a long time ago, when I was a medical student, ovarian cancer used to be considered a silent killer. Now we know that ovarian cancer has symptoms, and these symptoms predate a diagnosis. These symptoms, unfortunately, are non-specific and vague abdominal symptoms, which means that diagnosing them or picking the patients up is challenging. So the outcomes from symptom awareness and then testing women who have symptoms comes really from the DOVE study, which is a study conducted by Lucy Gilbert and team in Canada. And then we now have demonstrated implementation results from the NHS in the ROCkeTS study, which we've conducted in the UK. So the DOVE study tested women with symptoms. They tested 1,500 women who presented to a community clinic with symptoms, and they tested them with CA-125. And these women, out of 1,500 women tested, 22 women with cancers were diagnosed, and they compared this cohort to women who were presenting to clinic with symptoms. And what they found was, compared to a community testing strategy of women with symptoms, compared to women presenting to clinic, they found that in the DOVE cohort, women were more likely to have complete resections, 73% compared to 44%. The women in the community testing cohort were more likely to have less tumor burden, as shown by median CA-125 levels. And the majority were women who had good surgical outcomes. There was no survival outcomes that were published in the DOVE study. Our study now, we fast forward a few years after the implementation of symptom-triggered testing as routine in the NHS, and that is that essentially women are encouraged to present to their family care physician or their general practitioner, as they're called in the UK, with symptoms. And when these women present with symptoms, primary care are recommended to test with CA-125 and then with ultrasound, and then refer patients on to hospital through a pathway which is called a rapid access pathway, It's essentially an expedited timed pathway whereby there are strict timelines for when a patient should be seen if she's referred in this pathway, and then there are timelines for receiving treatment. And that's called the rapid access pathway. And essentially, GPs are encouraged to test women, and then if these tests are abnormal, refer via this pathway. So we conducted ROCkeTS, which was funded by the National Institute of Health Research, really to find out which tests were the best tests for ovarian cancer in postmenopausal women and premenopausal women with symptoms. So the primary aim for ROCkeTS was really to identify best diagnostic tests. However, as an exploratory analysis, we also conducted a piece of work that's been published earlier this year, but also figured a lot in the media as to whether symptom-based testing followed by expedited referral, which is standard of care in the UK, whether that contributes to early stage detection, diagnosis of low volume disease, and complete cytoreduction rates. So when we looked at the ROCkeTS data set, all of these women had symptomatic women, were symptomatic women, and they had abnormal triage tests because ROCkeTS recruited patients who were referred to rapid access tests in hospital. The study or the set of studies recruited from July 2015 to July 2022. And essentially, patients completed a baseline questionnaire. They underwent tests. The study stopped at the point where the patient had a histological confirmation by surgery or biopsy within 3 months. Or if the patient was managed conservatively or discharged, then we obtained follow-up data at 12 months, both through a participant-facing questionnaire as well as a research nurse-facing questionnaire. So of 2,500 participants, the majority of patients in the ROCkeTS set of studies were recruited through the rapid access timed diagnostic pathway. And you can see that 12% of women had ovarian cancer. The majority of them were epithelial cancer, and 119 of the 2,596 participants had high-grade serous ovarian cancer. And so our study focused on what did the women with ovarian cancer diagnosed through this route, what did these women look like in terms of tumor characteristics. So this is a set of pie charts, and I hope this is explanatory. When you look at performance status of these women, you can see that 95% of women have excellent performance status. Now, performance status matters far more than people perhaps think it does, because we know now, certainly in the UK from the work that we've been doing with the National Ovarian Cancer Audit, that one of the challenges we have for women presenting through emergency routes where maybe they've had symptoms, but it hasn't been picked up on, or maybe they haven't been tested, or whatever way they've been diagnosed as an emergency, we know that their performance status is extremely poor. And the majority of them don't receive, more women coming through emergency routes have a poorer prognosis because they are often not fit to receive chemotherapy. So having a diagnosis of ovarian cancer at a performance stage of 0 or 1 is absolutely excellent. And it means that the 95% of these women would have, under normal circumstances, been considered for treatment. If you look at the disease stage, again, this was really interesting because we found that 1 in 4 women of high-grade, 1 in 4 women who were diagnosed with high-grade serous ovarian cancer who had been referred on the back of symptoms and abnormal triage tests were stages 1 or 2. And we don't believe that there's a selection bias in this because recruitment was conducted by research nurses and knowledge of histology was a contraindication to recruitment, or as an exclusion criteria to recruitment, essentially. If you knew the woman had cancer, you couldn't recruit the patient to the study. So this feels like a very secure reflection of women presenting. When you looked at disease distribution, what we did in the course of the study was we asked research nurses to fill up a detailed questionnaire on what kinds of surgery people had had, and also how high the disease had spread in the abdomen. And you can see that a quarter of these patients had high spread, so in the upper abdomen, but the majority of them had low to moderate disease, which is essentially means pelvic and mid-abdomen confined disease. And these are the sorts of patients who would be completely cytoreduced or would have complete cytoreduction with bowel surgery and clearing the pelvis rather than needing extensive surgery like diaphragm surgery or splenic surgery. 66% of patients had primary debulking. This compares to over 3/4 nationally. So again, quite good. The 66% had primary surgery. This contrasts with nearly 3/4 of patients having neoadjuvant chemotherapy in the National Ovarian Cancer Audit. And if you look at surgical outcomes, 3/4 of them had complete cytoreduction or residual disease of less than 1 centimeter. So again, this is a very good set of outcomes from a diagnosis of ovarian cancer. So this is this in summary with the data in percentages and numbers. So essentially, the exploratory analysis we conducted of ROCkeTS was that 1 in 4 women diagnosed with high-grade serous ovarian cancer via this route of symptom-triggered testing and expedited referral were diagnosed with early-stage disease, low-volume disease. Most of these patients had primary surgery with high complete cytoreduction rates. We have not got, at this point in time, survival data. However, my PhD student is just applying for release of survival data from the National Cancer Registry. So I'm hoping that in a year's time, we'll be able to augment this paper and present the next paper on what the survival outcomes of these women was, which I think is at the moment lacking in literature. So let's place this in the context of what we currently know. We know that screening, both UKCTOX and PLCO trials were negative in the sense that UKCTOX demonstrated that it was possible to diagnose more early stage cancers, but that there was no survival benefit. And this paper, the UKCTOX paper, was published back in 2016. We've since had a more granular analysis of UKCTOX published last year in 2023. And that's this paper, which is the tumor stage treatment and survival of women with high-grade serous tubo-ovarian cancer in UKCTOX. And this is where the study authors, who are exceptional academics, have drilled down to look not at all patients with ovarian cancer, but specifically patients with high-grade serous ovarian cancer picked up in the screening arm versus the multimodal screening arm. And interestingly, what they've demonstrated was that the women who were diagnosed with high-grade serous ovarian cancer in the multimodal screening arm had more primary surgery, were diagnosed at an earlier stage, had better complete cytoreduction, and had a small but significant improvement in survival. And the authors of UKCTOX basically conclude that for us to be able to achieve improved outcomes from early detection, we would need to have better treatment options, which we currently do. When you compare what treatment options we have now compared to what we had 10 years ago or 15 years ago, we didn't have BRCA testing, we didn't have PARP inhibitors, we didn't have maximal cytoreduction surgery, we didn't have bevacizumab. So we now have many, many more treatment options. And they also comment that it's really important for us to ideally get to a point where we can do even better tests than CA125 for the diagnosis of pre-invasive disease. So it looks very much like the whole early diagnosis and screening space is going to be transformed over the next few years. It's really important to know that whilst I've been talking about the benefits of symptom-triggered testing, there are also harms of symptom-triggered testing. We know certainly in the UK that 97 women out of 100 premenopausal women will not be diagnosed with ovarian cancer. And these women often have a lot of anxiety of testing, and there is a workload and health system load that happens as a result of testing on the back of symptoms. And it's how we take women with us in this journey, where a cancer test is regarded as another test, like being tested for hypertension, for instance, because these two go hand in hand. Early diagnosis also will go hand in hand with more women being tested. Finally, ROCkeTS' results have been published, and they are incredibly exciting because our postmenopausal results published in Lancet Oncology this year suggests that using iota ultrasound adnex model, even with non-specialist sonographers scanning, can pick up about 96% of women with ovarian cancer with adequate, if sonographers receive adequate training and quality assurance. And we presented similar results, 90% sensitivity for ultrasound models in premenopausal women at the IGCS a couple of months ago, and we're preparing this for publication. So in summary, in totality, I think whilst we wait for the development of effective screening and prevention strategies based on our developments of our understanding of the molecular biology basis of ovarian cancer, symptom awareness and rapid diagnostic pathways increases the proportion of women diagnosed with early stage ovarian cancer, early stage high-grade serous ovarian cancer, and these women have better treatment outcomes. Survival outcomes not clear yet, and that's what we're working on. So further research is we need to understand what these symptoms mean for early stage, because this paper from this UK CTOX group suggested that maybe bowel symptoms were more important for early stage diagnosis. But also my particular interest is how we communicate these across different language speakers and different ethnicities, and what strategies we can use for community awareness of these symptoms. I think that area is really ripe for research, and can we detect these opportunistically via digital technologies and wearables and apps, for instance. So in summary, I'll wrap up. Ovarian cancer is associated with symptoms. These are vague and non-specific. Testing on the back of these symptoms is associated with diagnosis at an early stage and diagnosis at low to moderate disease distribution and good performance status. We are working on survival impact. Thank you for listening to this.
Thank you so much. That's just really exciting, actually, to hear just a positive kind of take on symptoms and early detection and its impact. And I really love that you are able to talk about this research in a way that is about the UK, but you can see, and you've touched on kind of some of that global impacts and the potential to impact across different communities. And I wrote down, as you said, about, you believe we'll see a transformation in the kind of landscape around detection and diagnostics in the coming year. And that's really from a disease area that's had so little progress and has been stumped for so long by these kind of challenges. Like, just wonderful to hear. And I wonder if you could, and it was very clear, but if you could just quickly recap maybe the significance of the findings from this study and what that could mean for women. And I really, I think the whole point about the performance status to me feels a very, very important one, that we want to amplify some messages around that and talk about survival benefit, what that means.
So the significance for ROCkeTS is that symptom-triggered testing was introduced into practice on the back of women having symptoms and the knowledge, exemplary work done by Barbara Goff, Willie Hamilton, Claire Bankhead, lots of people, finding that women had symptoms. At the point in time when symptom-triggered testing was implemented into practice, we'd had the Dove study, but we hadn't really got anything else that suggested that implementing symptom-triggered testing would have benefit. And so there continues to be a level of irritation amongst the clinical community, because there is a workload attached to this. And there is that piece of work around the vast majority of women tested, even with these triage tests, will not have ovarian cancer. So Ours, I think, is the first bit of data to say that actually, if you test these women and then you refer urgently and you then treat on a timed referral pathways, actually there is benefit. There is benefit to these patients. So I think that's the reason why ROCkeTS has been the analysis, the symptom-triggered testing for ROCkeTS has been so well received, and that's really the reason. And I mean, in the UK, we are blessed by being able to identify survival. So we'll be able to do that in a year or two. And I think that will be really profoundly, I think, helpful. And I think for the clinical community in particular, I do think amplifying this message is quite important, because I think sometimes people get bogged down by, gosh, we're seeing so many patients. What's the point in this? So I think it's really, there is point in it. And I think any opportunities to amplify the message to clinicians, I think, will be really, really important. I think the performance status thing, it's absolutely clear to me that if you diagnose women, nobody wants to be poorly. I mean, just from a human perspective, I think performance status directly, we know from the National Ovarian Cancer Audit that people are diagnosed as emergency presentations. Their performance status is poor. 1 in 4 women between stages 2 to 4 and unstaged in the UK, in England and Wales, will not receive anti-cancer treatment because they come in so poorly that they will not be fit to have carboplatin, which is actually quite it's not, it's very well tolerated chemotherapy. So I think being diagnosed at a performance status at a point and a disease load at a point in time where you can have standard of care treatment, extensive site reduction where you need to, and then have chemotherapy and then have PARP inhibitor or whatever is appropriate, is just so vital. You know, if you can't have standard of care treatment, regardless of how well you improve treatment patterns, then how are you going to benefit? So I do think that, and if you look at all the trial data that we've seen with the PARP inhibitor trials, performance status is excellent in those women in trials, as it normally tends to be. So I think this is why I think it's really important for us to get patients diagnosed at good performance status.
I couldn't agree more. And I find it, although I've heard it and from the UK, and I believe it's evidenced in many other countries, that figure of the 20% of women being diagnosed at such late stage. And I can't even imagine what it would be like to live to that point without a diagnosis, that it would be a very unpleasant existence. And that, and that I don't think is something we should accept. And it isn't.
No, exactly. I do think that's something I feel very, very strongly about, really. I think sometimes the early diagnosis spaces, understandably, for funders and for policymakers, they focus on stage shifts, and stage shifts are really very useful and helpful. But diagnosing in the context of ovarian cancer, diagnosing at a better performance status is a very worthwhile goal, I think. So personally, I think that's something that we mustn't lose sight of.
I agree. And it feels like we're kind of, as you say, maybe on the cusp of a little bit of but my next question is kind of to that point about, it feels sometimes like we haven't progressed. We still hear the silent killer kind of tagline, and we still talk to clinicians that, I feel are sort of hanging on to that and don't, haven't shifted that. And that may be unfair, but I'm, just from our work, I just wonder, what do we need to do to change the narrative? It feels like we want more ambition for more women, and our narrative around ovarian cancer maybe needs to shift.
So I do think that there is a piece of work for us to do on 2 fronts. I think firstly, I think we mustn't underestimate the challenges of diagnostics, because, from a family physician point of view, they are terrified of a diagnosis of ovarian cancer. They're terrified of missing it, but equally these symptoms are not so non-specific that there's a problem. We do need to, I think, raise awareness amongst women so they can proactively say, I was wondering if. So I think that's helpful. I think where we haven't been very good at is reaching out to physicians such as the palliative care physicians, the elderly care physicians, the general specialists, because I still see patients who have been moved down a best supportive care pathway, and then we're involved in as a sort of afterthought. And then you pitch up, and then you're retrieving the situation by saying, oh, no, hang on, we need to revisit this. We can make performance status better. We can give carboplatin. And that's a very uncomfortable conversation if the family have already walked down a different road. So that's a practical challenge that we face, I have to say. It might be a esoteric challenge, but actually it matters for that individual. So I do think that we have a real communication piece around women in communities to be tested and specialties outside of gynae oncology. And even within gynae oncology, I think advances in symptoms, or I'm always struck by how little airtime that this space receives.
I agree with you. And maybe that's our challenge, is increasing the airtime. So just as we wrap up, where next? You talked a little bit about, the next, the future of the study. And so where do you, for the study, but also generally, where do you see it?
So ROCkeTS has been very exciting. We've identified that when you test women with symptoms and you, with NHS sonographers, then with appropriate training, you can pick up most women with ovarian cancer. So there's a piece of work that we're doing to try and see if we can implement this in practice by providing people training, and we're in conversations about how one makes that happen in the context of the NHS. We've got another study called Sonata, which we'll be reporting next year, which tests if a test called Roma is better than CA125, and we're testing 37,500 women.
Wow.
Samples. So with those results next year, hopefully middle next year, if not the year after. And that I think will be really exciting, because I think I don't know if it's positive or negative. I haven't got a clue on the results. So that will be interesting. I think we're involved in lots of new and exciting research on new things like circulating tumor DNA, on metabolomics. So there's lots of interesting things that we can do to try and find women when they have either very few symptoms or so I think it's understanding all of these things. And then there's pieces of work that we're doing to try and improve community awareness where I practice. And again, that's a whole space in itself, in terms of how does one reach. I mean, I practice in a very diverse, very ethnically diverse and very deprived population. How do you increase awareness without increasing anxiety? And I think that's the holy grail, really. I'm not sure. I'm not sure how far I will go in that journey, in the sense that is the holy grail, but let's see where we get.
And I think you're wonderful, especially because you come with that very hands-on experience living in a community where the challenges are very real, and the inequities and barriers are, right in front of us. And still they are hard to overcome. And the way that you bring that into your research interests, I think, is just an amazing thing. So,
Thank you. Thank you.
And I, love to have you back next year to kind of talk about all those really interesting things that are happening and coming down the track. But for now, we'll draw this to a close. But just thank you so much. We just really, really appreciate it.
Thank you.
Thank you for taking time out of what is a very busy day, I know.
Thank you. Thanks, Clara.
Thank you.